Sickle cell disease is an inherited disease characterized by the possession of abnormal hemoglobins, at least one of which is hemoglobin S. So there are various types, including HBSS, HBSC, and HBS beta thalassemia. The possession of one normal hemoglobin, as hemoglobin A, together with one abnormal hemoglobin, for example AS or AC, constitutes a hemoglobinopathy trait and not sickle cell disease. So the use of the word sickler to describe patients with sickle cell disease must be avoided. Sickle cell disease patients may present either in a steady state, in crisis, or with complications. The crisis is commonly vaso-occlusive bone pain crisis. Other types of crisis include acute chest syndrome, hyperhemolytic crisis, aplastic crisis, and sequestration crisis. In vaso-occlusive crisis, there is occlusion of small vessels by sickled cells, causing infection and pain. And in acute chest syndrome, the patient presents with sudden onset of cough and difficulty in breathing and fever. In aplastic crisis, infection with parvovirus causes severe sudden anemia with a low reticulocyte count. And in sequestration crisis, the spleen and liver enlarge rapidly due to trapping of red blood cells. Patients with sickle cell disease should be encouraged to have periodic checkups at the sickle cell clinic. Causes: inheritance of two abnormal hemoglobin genes from both parents, at least one of which is an S. Crises are typically precipitated by cold weather, dehydration, infection, physical exertion, mental stress. And also symptoms are joint and bone pain, especially during cold, wet seasons, easy fatigability, pallor, jaundice, difficulty in breathing with or without chest pain, chronic large ulcer, abdominal pain, especially in the splenic area, spontaneous sustained erection without sexual arousal in male patients, that's priapism. Signs that are usually elicited are jaundice, pallor, hepatomegaly, splenomegaly, which may be absent in older patients, old or recent scarification marks by traditional healers, particularly over the abdominal wall and joints. Also venous ulcers, bruising, dactylitis, as in hand and foot syndrome, and natopathy, as growth delay or tall, blanky stature, as malphanoid habitus. So investigations are FBC, blood film comments, reticulocyte count, sickling test, hemoglobin electrophoresis, urine examination, chest x-ray in case of ACS, that's acute chest syndrome, and also blood and urine CS, that's culture sensitivity when infection is suspected, and Jesus PD assay. So treatments. So the main treatment objectives are to prevent the development of sickle cell crisis, to relieve pain, to identify and manage the precipitating cause of crisis, to maintain a good steady state hemoglobin, to prevent long-term complications and organ damage, to maintain sickle cell crisis and complications once developed. Non-pharmacological treatment: good hydration at all times by drinking adequate water or fluids, avoidance of common precipitating causes of crisis such as malaria, dehydration, stress, excessive exercise, and exposure to extremes of weather, maintenance of good nutrition, client education, parental or guardian education, genetic counseling with a voluntary family size restriction, general public knowledge. So pharmacological treatment for vaso-occlusive bone pain crisis: first line treatment In mild to moderate pain, you give paracetamol oral. In adults, 500 milligrams to 1 gram, 6 to 8 hourly. In children, 6 to 12 years, you give 250 to 500 milligrams, 6 to 8 hourly. 1 to 5 years, you give 120 to 250 milligrams, 6 to 8 hourly. And 3 months to 1 year, you give 60 to 120 milligrams, 6 to 8 hourly. Or paracetamol rectal. Adults and children, you give the same dosage. Or you can give ibuprofen oral. In adults, 400 milligrams, 6 to 8 hourly. In children, 6 to 12 years, you give 200 to 400 milligrams, 6 to 8 hourly. And also 1 to 5 years, you give 100 to 200 milligrams, 6 to 8 hourly. And from 3 months to 1 year is not recommended. You can also give diclofenac oral. In adults, 50 milligrams 8 hourly or 100 milligrams 12 hourly. And in children more than 12 years, you give 50 milligrams 12 hourly. Less than 12 years is not recommended. And also can give diclofenac rectal. In adults, 100 milligrams daily up to a maximum of 200 milligrams daily in divided doses. In children, 75 to 100 milligrams daily. Can give morphine sulfate oral or IV, but consult specialist. And also you give dextrose in sodium chloride IV infusion. In adults, 5% dextrose, 0.9% sodium chloride, 2 to 4 liters daily. In children, 5% dextrose in 0.9% sodium chloride, 150 milliliters per kilogram daily. Or in adults, you give normal saline alternating with 5% dextrose, 2 to 4 daily. That's 2 to 4 liters daily. In children, normal saline alternating with 5% dextrose, 150 milliliters per kilogram daily. So fluid requirement in children according to age: less than a year, you give 50 milliliters per kilogram. 1 year, you give 140 milliliters per kilogram. 2 years, you give 130 milliliters per kilogram. 4 years, 110 milliliters per kilogram. 6 years, you give 100 milliliters per kilogram. 8 years, you give 90 milliliters per kilogram. 10 years, you give 85 milliliters per kilogram. And 12 years, you give 70 milliliters per kilogram. For severe pain, second line treatment, you give diclofenac sodium IM in adults, 75 to 150 milligrams daily in divided doses. And then you give codeine phosphate oral in adults and children over 12 years, 30 to 60 milligrams 4 to 6 hourly. Or you give tramadol oral, 50 to 100 milligrams 8 hourly. And blood transfusion as packed cells when needed but not routine. Transfusion will be necessary if hemoglobin levels is less than 5 grams per deciliter. For steady state, you give folic acid oral in adults 5 milligrams daily. In children more than 1 year, you give 5 milligrams daily. Less than a year, you give 2.5 milligrams daily. And for severe disease, you give amoxicillin plus clavulanic acid IV, 1.2 grams, and urgently transferred to a tertiary center. You can also give hydroxy, carbamide, aspirin, opiates, or chronic transfusion therapy may be used under specialist care. Okay, so prevention of pneumococcal infections, I give pneumococcal conjugate vaccine 13, that's PCV 13 vaccination in infancy, booster at in infancy, so booster at 6 years. The referral criteria: refer all sickle cell patients with bleeding into the eye, priapism, hematuria, or renal disease and stroke to a specialist. The presence of osteomyelitis, septic necrosis of the hip, acute chest syndrome, and persistent jaundice after initial management as recommended should also warrant a referral to a specialist center. Patients with central nervous system events, unexplained high white cell and platelet counts more than 15 and 500 times 10 raised to the power 9 liters per liter respectively, and also intractable morbid pain, repetitive crisis or recurrent severe anemia interfering with their lives should be referred to a specialist.